Good afternoon, everybody. On behalf of the National Office of Traffic Medicine, an initiative of the Royal College of Physicians in Ireland and the RSA, I'm delighted to welcome you to our annual launch of the updated Sláinte agus Tiomáint Medical Fitness to Drive Guidelines. This is our 9th edition. We have gone back to 2001 in what is a unique initiative in world terms, and we are the only traffic medicine grouping which is embedded in a postgraduate medical college and which unites so many disciplines, not just medical, but health and social care professionals and many other stakeholders as well. We're also delighted that is now our habit and our custom is to introduce 3 new driver information leaflets, because as we become clear, as we talked through our process, this is very much a collaborative venture between the professions, between the RSA and its National Driver Licensing Service and drivers. And together we aim to maximize safe mobility so that you are not limited unnecessarily by any medical condition, but also you know what are the limitations or what are the responsibilities you need as a driver. So the overview today, as was sent out to those who were involved, is a welcome from myself, a brief overview of the office, a few words then on our update of the Medical Fitness to Drive Guidelines in common with many other jurisdictions such as the UK, Australia and Canada. We update our guidelines on the basis of upcoming evidence, but also very much feedback from our stakeholders. Then we're going to have 3 brief introductions from leads in the relevant areas on our new leaflets. The first one on stroke, transient ischemic attack and driving. The second one on vision and driving, and that will be from Mr. Sean Chen, consultant ophthalmic surgeon. And lastly, and with a due word of caution that of course pregnancy is not a medical condition, it's a natural condition, and we certainly don't wish to be seen in any way to medicalize it. But there are elements around pregnancy, everything from wearing your seatbelt properly to protect mother and baby, to what happens after surgical intervention or cesarean section, that's really helpful and useful. And both service users and the professionals have welcomed this development. The next piece then is we're part of an international consortium looking at evidence base behind medical fitness to drive guidelines. And our part from Dublin, the lead was on alcohol and crash risk, and we'll run through our systematic review, which will be published shortly. Then we're delighted to have an address from Professor Mary Horgan, the President of the Royal College of Physicians. And the College of Physicians has very much taken a lead as a servant, as leader for all the other postgraduate colleges and professions to be supportive and provide an environment within which we can develop a framework for continued safe driving with medical conditions. We will have time for some questions and answers then. And then lastly, remarks from Mr. Declan Nocton, who's the Director of Driver Training and Licensing in the Road Safety Authority. And the Road Safety Authority is really to be commended for a very positive, enabling approach to medical fitness to drive, recognizing that actually being able to get around mobility transport is a vector of health. We have apologies from Dr. Declan Bedford, our chair of our steering group, which will become clear in the process, who's unable to join us, but has been a staunch supporter of the whole enterprise. Our National Office for Traffic Medicine has 4 main pillars within which it works. Guidelines, which we update every year, and which actually a number of other countries have now asked for permission to copy and use. This is based on research, so we have an active research portfolio, but as I'll explain about the updating of the guidelines, we also undertake a yearly literature review of all the literature in the area on medical fitness to drive. We base this on working with a large working group and then specialist groups in the areas of substance abuse and vision, so that it's very much grounded. And everybody who's on the working groups is a representative of group. They're not there in a personal capacity. And lastly, an important education role, which we'll cover briefly. And then it's really important to get communication out, and this launch today is part of a broader communication effort, ably supported by the communications offices of both the College of Physicians and by the Road Safety Authority. The office itself, I'm the director, part-time, full-time manager, Dr. Margaret Ryan, a traffic psychologist. Our program coordinator is a healthcare professional, Lily Roach, and a nurse. Chair of our working group, Dr. Declan Bedford, public health physician, with the leader in the public health of crashes and accidents, a working group of over 30 disciplines and stakeholders, and a steering group which is joined between the Road Safety Authority and the College of Physicians. All our work is done on the basis that there are shared responsibilities. This is not all on the doctor's shoulders. The driver has responsibilities. Healthcare professionals, and not just doctors, alcohol counselors, nurses, therapists, all have a role in advising when they see it. If you see it, you own it. And lastly, the National Driver Licensing Service, which needs to provide a framework with regulatory and otherwise, and also to include increasingly European community legislation, which is fostering a supportive environment. So in terms of driver awareness, we've been very active here in terms of attending events like the National Ploughing Championships, the Over 55s, the Tullamore Show, and generating a series of leaflets, which is quite unique in international terms. And indeed, some other jurisdictions are thinking of engaging in a similar process. And we also engage with advocacy organisations such as the Alzheimer's Society of Ireland, and have prepared literature on Alzheimer's disease and driving. We also take this in the context where we feel very much justified in this, and we've done one of the first papers in the world literature looking at the general public's attitudes towards risk and personal responsibility in the context of medical fitness to drive. And what is found is that there's actually a significant need and a lack of awareness in many areas around who is responsible for risk and personal responsibility in medical fitness to drive. We're also trying to be very current, and one of the areas that's important, for example, is we had a significant number of questions in around the impact of COVID-19 on fitness to drive. Particularly one element that arose in the popular press was that of whether vision can be impacted. And in fact, what we've been able to show through a review of the literature is that vision is not significantly impacted in COVID-19, but anybody who has concerns should not take a test drive or similar, but should contact their physician and ask. There's no particular evidence in other areas other than, I suppose, the key one, and it isn't really worked out in terms of figures and statistics, but fatigue is a known accompaniment of COVID-19. And as fatigue and sleepiness is a major issue in the causation of crashes, people need to be doubly mindful, should they have had COVID, around fatigue, taking a rest, and stopping if they have any sense of tiredness. So that's probably the main thing in terms of guidance and advice. Our education portfolio includes first in the world in certificate in traffic medicine, which is heavily subscribed by doctors and occupational therapists, and with significant international interest as well. We run yearly clinical updates in the College of Physicians, which are forthcoming one in October around substance and alcohol use. And then we reach out to undergraduates with an undergraduate essay prize. So coming to this year's Sláinte agus Tiomáint, I think those we really do emphasize, and one of the reasons we run a launch and we get publicity is people must ensure that they're using the current version of the guidelines, and delighted to see a different and easier to read graphics layout, a new cover, and just a little bit about the process of what we do. So every year, and I'm in the middle of it at the moment, we do a literature search on what's new in traffic medicine. And the good news for traffic medicine is that this whole area is increasing in intensity of research from year to year. We then divide this into the various areas of interest. We circulated the work group for comment, annotating those which we think may have an impact. We agree revisions in November, and then we send the guidelines for external review. At this stage, we've managed to send our guidelines to experts around the world, Sweden, Australia, Canada, and this year we're delighted to have our expert from Ann Arbor, which is UMTRI, is one of the world's leading transport research institutes, and we had some really interesting comments. Also, it's quite interesting each time, without getting a head swelled, each time we do an external review, nearly always the reviewer comes back and said, I wish we had some of this in our country. But each time they come back to us with really interesting suggestions, and this year was no exception from Professor Lisa Molnar in Ann Arbor's Transport Research Institute. The reviewer suggestions are incorporated and signed off by the working group. So what's new this year in particular? Increased and updated referencing to the evidence base, and it's really is important. I think one of the other things we do is we have one-to-one training with new judges coming in, and I think particularly when people are going into court, maybe feel they may have to go into court at some stage, it's good to know that there is an updated reference to the evidence base of our recommendation. There's improved system-based indexing at the back, and this is towards next year. We will have fully digital guidelines which can be searched on the basis of a symptom, that you key in a symptom. At the moment, people are searching on a PDF, which is useful, but certainly on phones and similar, it'll be easier with symptom-based, web-based digital indexing. We've introduced interstitial glucose monitoring for the first time, so that's on the basis of recommendations from the UK, the European Union. We've increased advice on alcohol and substance use disorders, and this is very much a neglected area, as will become apparent when I undertake the review of alcohol and substance use alcohol disorders, which we undertook as a research element. And it's interesting that doctors don't seem to treat alcohol use disorders as a medical condition, and it seems very much neglected in terms of being able to do positive things. And we're particularly interested that brief counselling has been shown in a number of studies, for example, in the emergency department for alcohol use disorders, to reduce all forms of injury and violent death, including domestic violence. So it has a broader reach. The patient leaflets are included so that family doctors can engage with what their patients are reading. And because these are effectively PDF and digital documents, what we're doing is we're adding to the green agenda. I know both the RSA as a government state agency and their College of Physicians are very much the fore in promoting the green agenda, and we're looking very much towards this paperless form for both the guidelines and the leaflets, but it also adds that degree of flexibility as well. So with that, I'm delighted now to be able to start introducing our three speakers on our three leaflets. We'll start off with stroke, transient ischemic attack and driving, and the talk here will be from Professor Ronan Collins, a colleague of mine, who's the National Clinical Lead for Stroke in Ireland, has been a researcher way back into the 1990s before stroke was really on the horizon. So I'm going to stop sharing my screen now and hand over to Lily Roach, who's going to coordinate the video from Professor Collins.
Good afternoon. My name is Ronan Collins, and I'm the Clinical Lead for the National Stroke Programme, and I'm delighted to be invited to launch the new guidelines from Sláinte agus Tiomáint with regard to stroke and TIA and the driving assessment of patients after the stroke and the TIA. Stroke is our commonest cause of acquired adult neurological disability, and in Ireland we get somewhere between 7,500 and 10,000 strokes per annum. Up to 25% of strokes occur in adults of working age, and this percentage is increasing, of course, as older people are increasingly healthy and choose to continue working, or are working informally as carers or providing childcare for members of the family. Driving is a key enabler of independence, work and recreation in all our lives, and so the advice with regard to driving is very important after stroke and TIA. Restoration to living is one of the 4 key pillars of the National Stroke Programme strategy, and driving is a very important part of returning to a full life after stroke and TIA. The guidance is clear and concise and advises patients importantly that they must always inform their insurance company whether they have had a TIA and a stroke. The guidance makes it clear that there is no need to inform the National Driving Licence Authority in Group 1 category driving licence holders if they've had a TIA or a stroke which has no persistent, significant neurological symptoms or disability. However, all Group 2 driving licence holders should inform the NDLS if they've had a TIA or a stroke in all circumstances. The rules are made simple in this new guidance leaflet with regard to returning to driving after stroke and TIA. For all Group 1 licence holders, patients should not drive for at least a week after a TIA. In all Group 1 licence holders, patients should not drive for at least 4 weeks after a stroke and be medically assessed to be fit to drive. The guidance makes it clear to physicians that in assessing fitness to drive after a stroke, factors that should be considered carefully are patient's vision and whether there is presence of any visual field defects, whether a patient's cognition has been affected by a stroke, whether the patient has suffered a seizure after a stroke, and whether that seizure could be considered provoked, occurring within the first 24 hours of the stroke, and therefore may be considered slightly differently as to a formal vascular epilepsy, which is more prone to recurrent seizures. The guidance also lays out the importance of assessing patients for fatigue after a stroke, and as to whether there are any underlying remediable causes for that fatigue, such as obstructive sleep apnea, which in itself can be a risk factor for stroke. The guidance also points to physicians to carefully assess the power, coordination and sensation in stroke patients' limbs, and this is particularly important where patients are driving a manual car, where dorsal and plantar flexion are very important for both acceleration and for clutching, and the guidance prompts us to consider whether a patient should switch to an automatic or have the car adapted in such circumstances where there are persistent, significant neurological disabilities affecting the limb. In the case of Group 2 licence holders, patients should not drive for at least 3 months after a stroke or a TIA, and again in such circumstances must be medically deemed to be fit to drive. And so in summary, it is a pleasure to be asked to contribute to this symposium on the new driving guidance and guidelines from the Sláinte agus Tiomáint programme, and thank you for the opportunity, and we welcome these guidelines as being clear and concise and giving physicians a very clear, and patients also a clear picture of what the situation is with regard to driving after stroke and TIA.
I will give an overview of our study of the influence of alcohol use disorders on crash involvement of motor vehicle drivers. This may seem to be a given. It may seem to be one of those things you're wondering, well, why on earth would you need to look at this? Because we do know, and it's been regularly disseminated in the media, that alcohol is a feature in 1/3 of fatal crashes. However, we have undertaken some preliminary work about this a few years ago because we're interested in the neglect of alcohol use disorders by healthcare professionals in general, or their aversion to facing it directly. And in fact, the relation of alcohol use disorders is unknown largely, as it's rarely followed through to diagnosis. And it's very much by proxy, either through the proxy of knowing that in states in the US that have higher levels of alcohol consumption, there are higher levels of alcohol-related crashes that are fatal and injurious. We know it through the level of alcohol use. We know it through one of the sub-syndromes of alcohol use disorders, binge drinking, that there is a relationship as well. But actually for alcohol dependence, we had a strong sense that we know a lot about alcohol in fatal crashes, about people being over the permitted level. This is known as driving under the influence, or DUI or DWI. And our concern was that there wasn't an evidence base for risk calculation for the doctor or other healthcare professional who came across somebody who hadn't yet been in a crash or who hadn't yet been detected as driving under the influence. So we've been involved with a collaboration across 6 sites, generated by Vic Roads, which is the equivalent to the Road Safety Authority for the state of Victoria in Australia. And they have undertaken an update of one of the seminal works on medical fitness to drive, which was a Vic Roads documents from 2010. So our partners in this are ourselves in Dublin, Monash, there's MUARC, the Accident Research Centre, one of the premier research centres in the world. Our own particular partners in the UK were specialists in addiction, psychiatry, and then the head of medical fitness to drive in the province of Quebec in Canada, Jamie Dow, and then the leader in psychiatry and driving, Mark Rappaport in Toronto. So we've undertaken a range of topics to look, has the evidence base changed? Should we be changing our recommendations? So do the Charlton Shan couple in Melbourne looking at epilepsy, sleep disorders, psychiatric disorders led out by Mark Rappaport in Toronto, diabetes, and now hearing led out by Jamie Dow in Quebec, and alcohol dependency and abuse led out by ourselves and our researcher Monica Perizzolo. And I have been involved already for the National Office in Traffic Medicine in systematic reviews for stroke, traumatic brain injury and dementia, all of which have already been published, and these will go into the omnibus report. So our lead and collaborators here are Dr. Monica Perizzolo, a traffic psychologist who undertook to work with us as a postdoc, Dr. Margaret Ryan and myself, Dr. John Sheehan and William Flannery from the Mater Hospital, specialist in addiction psychiatry, Professor Ailish Gilvary in the University of Newcastle, Professor Colin Drummond in King's College London, Dr. Maurice O'Dell, a forensic psychiatrist in Monash in Melbourne, Jamie Dow in the University of Quebec, Mark Rappaport in the University of Toronto, and Shannon Copland, Judith Charlton in Monash. So the research question was, and again, I think the surprise here for many doctors and lay people will be that this evidence wasn't more clear. What is the motor vehicle crash risk for drivers with alcohol-related disorders, misuse, abuse, dependence, with inclusion in relevant studies without confirmation of a record of driving under the influence, DUI, or with inclusion in studies arising from DUI? Because our preliminary research had shown that the studies seemed to be weighted towards DUI, driving under the influence. The systematic trial was registered, as all of these reviews have been, with Prospero, which is the International Prospective Register of Systematic Reviews. So as in many of these systematic reviews, you start out with an enormous number of papers, which we screened independently with third-party reviewing. So 8,223 to start with, one identified through bibliographic research, duplicates removed 3,252, down to nearly 5,000 we screened. We excluded 4,930, looked at 41 for full text eligibility, that brought it down to 33. Then studies that didn't include crash risk or a non-road driving test, knocked out 27. studies which didn't include drivers with a medical condition, 6, and we were left with 8. And for anybody involved in systematic reviews, this is not uncommon, and particularly an area that's really only come to prominence in the last 10 to 15 years. Sorry, I beg your pardon. So 8 studies, 7 stated the risk to be elevated, but there was a range of qualifiers. The odds ratios ranged from 1.1 to 4.6, and give some comparison here. The odds for diabetes is about 1.1 to 1.2. The odds for sleep apnea is 2. But the qualifications included the proportion of those involved as drivers. So in one study, for example, 53% of them were clearly drivers, but we don't know about the other 47%. Sometimes there were studies of drivers who'd been caught with violations, and clearly that's a selected group. And there was a graduation of risk with severity of alcohol use disorder. However, most interestingly, probably the highest quality paper found a reduced crash risk with alcohol use disorder. And there's a number of reasons for this, such as the impoverishment of alcohol use disorders, that you may not actually have a car, or that you may already have killed yourself or put yourself off the road through injury. And the level of evidence was variable, with 3 graded as good, 4 graded as fair, and 1 as poor quality. And in our write-ups, we're going to eliminate those with poor quality. So our recommendations are that alcohol use disorders should continue to be considered a risk for motor vehicle crashes. There should be increased attention to ensuring accurate diagnosis of alcohol use disorder in both patients who present to you with a probable history of heavy drinking, binge drinking, but also in people who've drivers with heavy drinking patterns, binge drinking, known alcohol use disorder, and traffic violations and crashes, and to consider it in a therapeutic sense, treatment and follow-up. We should ideally have further research pursuing linking health records with the diagnosis of alcohol use disorder, treatment outcomes, and crash involvement, to do a little bit of work around deciding what might be the appropriate length of time to be abstinent. And we need more formal recommendations for detection, assessment, and management of binge drinking in the context of medical fitness to drive. So that's our study, and indeed there may be some questions thereof. So I'm going to stop sharing now, and hopefully our films recorded talks will be back from Lily and Margaret. So we're now doing Dr. Sean Chen.
Good afternoon, everyone. I'm Sean Chen. I'm a consultant ophthalmic surgeon in Galway, and I contribute to the Vision panel of traffic medicine in Ireland. I'm honoured to be asked to introduce this new and important leaflet informing everyone, public and medical professionals alike, about safe driving and vision. The world is changing, but safety for driving is not, and is unlikely to do so even with the increasing automation of vehicles. I say this because pedestrians and cyclists also use the road, and passengers in vehicles can also be injured and die on the road. In a very important publication from Dr. Margaret Ryan and Professor Desmond O'Neill recently, it is clear that public willingness or understanding, or both, of their responsibility to self-declare changes in their fitness to drive is lower than desirable. Interpreting this behavior is problematic and requires further research. But on a human level, it could be related to a fear that declaring to the authorities something that may reduce the person's ability to mobilize or make a living can be a real barrier to compliance for self-declaration. I believe that the solution to such a dilemma is multi-pronged. We must first instill a sense of civic duty. We must also increase the knowledge around situations that could compromise one's visual ability to drive. We must also create reassurance that self-declaring does not automatically mean driving disqualification, and could well, in very many instances, lead to further facilitation of visual improvement. Of course, there is also the consequence of not self-declaring and the penalties that may ensue. This leaflet goes some way to addressing these remedies, I believe. The remainder of the journey comes from its widespread promotion through launch events such as these, and further research into the changing attitudes as a result. In the not too distant future, an interesting development will be related to how driver responsibility may change as vehicles become more and more automated as a result of artificial intelligence and its increasing role in human life. I'm sorry I'm not able to be there in person, and hope that you all enjoy this event. I look forward to the beneficial effects of these and other interventions for safer roads in Ireland. Thank you.
Good afternoon. My name is Dr. Sorcha O'Brien, and I am currently a final year Specialist Registrar on the Obstetrics and Gynecology scheme. First of all, I'd like to congratulate both the College and the Department of Traffic Medicine on the launch of this new information leaflet today. I would also like to thank them for involving me in the launch. Like many things in pregnancy, it can be difficult to define risk exactly because pregnant people are mostly excluded from research studies. Looking at Canadian emergency room data, it has been suggested that the risk of accident slightly increases in the second trimester before returning to baseline in the third trimester. It is important to note, however, that pregnant people are far safer drivers than some other groups on the road. The risk of accident actually decreases below pre-pregnancy rates after birth. A lot of the recommendations are common sense. They deal with the logistics of how to cope with the ever-expanding pregnancy bump, how to appropriately wear a seatbelt in a safe way, and they also advise regarding watching out for the common symptoms of pregnancy, such as nausea, tiredness and lethargy, that may affect our day-to-day functioning and as a result can impact our ability to drive. After birth, women can drive when they feel able to. It is important to dispel the myth of a 6-week blanket driving ban after caesarean section, which has not been mandated by anyone. It's largely based on concerns regarding insurance cover. Pregnant people should listen to their bodies and trust their instincts, and they should drive when they feel fit to do so during and after pregnancy. They can, of course, consult with their doctor or midwife if they feel that they need to. And they can also check with their insurance company if they have concerns regarding cover after caesarean section. We have run the language in the leaflet past a women's health campaigner and a midwife who felt it was accessible and clear in the message. There are also some very helpful links to videos regarding wearing a seatbelt and dealing with car seats for babies and premature babies. We hope this information leaflet provides pregnant people with reassurance and confidence in their own ability to trust their own instincts and bodies, and to drive when they feel they wish to. We are delighted to launch it today and hope it provides helpful information to the pregnant population going forward. Thank you.
Thank you very much. So delighted to have these presentations from Mr. Sean Chen, who's been on our special interest working group for some time now, very closely linked with the DVLA, and has also been involved with research for us. And equally delighted to have Dr. Sorcha O'Brien, a specialist registrar who in obstetrics and gynecology. And we'd like to particularly also thank Dr. Brendan McDonnell, who played a major part in helping bring this leaflet together. And all of these leaflets have, as helpfully pointed out by Sorcha, passed through advocacy groups and passed to the RSA as a very useful function making sure that in terms of literacy, that these are accessible to the broadest range possible in the public, and these can be accessed on the NDLS website, on our own traffic medicine website, and we certainly would like the word to be spread. So the forum is open now for questions. We'd like to make an apology over the non-availability of Professor Collins. There was a technical fault with the sound, and it felt it would be very challenging. So I'd like now to ask, we don't seem to have any questions at the moment, and as our three panelists unfortunately are unable to with this, I'm happy to move directly to Professor Mary Horgan, President of the College of Physicians.
Hello, I'm Professor Mary Horgan, President of the Royal College of Physicians of Ireland. I was delighted to be invited to participate in today's launch. The Office of Traffic Medicine is housed within the Royal College of Physicians of Ireland and is led by our council member, Professor Desmond O'Neill, who works with Dr. Margaret Ryan to ensure the development of education and research in the area of traffic medicine. This is essential for us healthcare workers, but also for the public, to ensure that safe driving is always a priority within this country. Indeed, the work of Dr. O'Neill and Dr. Ryan has been imitated in many other areas of the world, as they are foremost in the development of the education and research within this important field of medicine. Today, there will be a launch in areas of pregnancy and driving, and we do have the Institute of Obstetricians and Gynecologists within the college, which is the training body and educational body for all of the obstetricians and gynecologists within the country. Secondly, the area of stroke and transient ischemic attacks and driving is also being launched today, and again with the participation of another council member, Professor Ronan Collins. And lastly, the area of vision and driving is being launched. Many of the medical ophthalmologists throughout the country are both members and fellows of this college, and it is great to see their work coming to fruition. The area of research is very important in medicine, and Professor O'Neill has led on many research initiatives that have helped inform us of how best to develop and educate people around the area of traffic medicine. And you will see from the website the many research publications in the area, again, led by Professor O'Neill and Dr. Ryan. I wish the launch every success today, and the College of Physicians looks forward to continuing to support this very important initiative, which at the end of the day ensures the safety of the people of Ireland. Thank you.
Great. Thank you very much, Professor Horgan, and we're again very appreciative of the support, and I think it's been a mutually beneficial relationship, but I think it's very much in the portfolio, as you've outlined, of advocacy, engagement with the public. So we have one query in. If a person has a new medical diagnosis, at what point are they required to...
I hand back over to Des. Des, are you there?
Yeah. Apologies. Can you... Okay.
Can you hear you now, Des?
Okay, great. If a person has, we thank you very much, Mary, and we very much appreciate the input and support of the college. It's very much within the portfolio of advocacy, of engaging with the public, and a role very much servant as leader. We've a number of questions. If a person has a new medical diagnosis, at what point are they required to self-declare to the NDLS? Is that diagnosis at the outset, or at application or renewal? Our aim is that if you're not at all certain, our first suggestion is that you go to the website to see is the condition you've got among the leaflets we have. and in all of our leaflets make it clear which things you need to report to the NDLS there and then, and which things don't need to be reported. If you're not certain, do ask your family doctor in the first instance. They nearly all now have a very high level of awareness of the guidelines, and they can download the guidelines. And indeed, the guidelines are also available. If you go to the NDLS website, there's no secrets here, no secret door. The guidelines for the medical doctors and the other healthcare professionals are equally accessible to the general public. So we make it clear, the phrasing is should report to the NDLS. A second question is, the medical fitness to drive guidelines continue to apply to electric and hybrid vehicles? And the answer here, Declan may or may not wish to come in, but the answer is yes, there's no particular difference between electric and hybrid vehicles. One of the interesting areas will be the autonomous vehicles. And we are keeping a watching brief on this. We've been involved in an advisory capacity to an Irish consortium on autonomous vehicles. And I link into the US Transportation Research Board to a number of states which have licensed autonomous vehicles. At the present moment, California, for example, is expecting the same medical fitness to drive guidelines for autonomous vehicles as for standard vehicles. This is largely around the whole process of actually telling your car what to do and where to go, and also around what to do should you be involved in a crash. So it's not so much the issue of a quick reaction time particularly, but vision clearly and other things will be important, but we're keeping a watching brief on this. We aim to have this webinar up for viewing on the college website, but the date won't be determined, but we'll do this as soon as possible. We'll have to do a little bit of tidying up because of our technical glitch. So I'd now like to welcome Mr. Declan Naughton as our final speaker before we wrap up from the Road Safety Authority.
Okay, thank you very much, Des. And it's great to be involved from the RSA's perspective with an event like this. The role of traffic medicine is becoming ever more important in our daily lives. It speaks to both the medical profession, but also to every road user. And I guess today's event highlights both of those aspects. So we have the updating of the Sláinte agus Tiomáint guidelines for medical professionals, and we're also launching the leaflets. And the leaflets speak in plain language to various parties who are road users, but who may need help and support. So we try and in traffic medicine, try and cover both those bases. To me, the National Office of Traffic Medicine is an exemplary body. The RSA and the RCPI came together a number of years ago to bring it into being. And I think we only know its value because some of us knew what was there before. And huge strides has been made in the area of traffic medicine in this country in the last decade. To such an extent that when a recent review of the Commission driving directive was made, we were found to be ahead of the curve in lots of aspects. And I'd have to acknowledge the role that the Office of Traffic Medicine played in getting us to that point. Obviously, it punches above its weight, and we heard Professor O'Neill talk about the engagement with Monash and other stakeholders in terms of alcohol and how that impacts on driving, and some very surprising findings coming out of that. And obviously food for thought here in Ireland, because we know drink driving and drink consumption is a problem, but where we're less certain of our footing is what happens on the ground. How do people drive? How are they impacted by drink? And what's their understanding of what they should do in certain situations? So I think there's a bit of work to do there, and it's a source of conversations that I have with Professor O'Neill and Dr. Ryan in terms of where we go on this, but it will be something that will take up more and more of our time in future. I think also this collaboration between ourselves and the RSA, between an NOTM, Office of Traffic Medicine, and other European bodies. So for example, we're currently looking at on-road driving assessors. So these are people who may be called on by GPs to carry out a test of certain drivers to see what the practical driving looks like and report back to them to support them in any diagnosis they make. So by being part of that, we're there contributing to the broader medical fitness area and contributing to the EU and future directives as well. So it's great for me as part of the RSA to be able to say we have that capability to be able to contribute and make a contribution to the broader European framework. A number of speakers mentioned today that we all have personal responsibilities of drivers. And I think the core message going out today is that the RSA and the Office of Traffic Medicine supports mobility to the greatest possible degree consistent with safety. But we're also looking to drivers, and that drivers know what their own responsibilities are, because essentially it starts with you. We'll do our piece, but it's very critical that all drivers A, are aware of their responsibility, and B, act accordingly. Thanks very much.
Appreciated. And again, as I said, that philosophy is very much appreciated, and also that you've brought in that element of how our group feeds into a European driver licensing legislation and ongoing improvements. So I'd just like to thank everybody. I answered the last open question on text, available to all, and just a number of people I'd like to thank. I'd like to thank Dr. Margaret Ryan and Lily Roach in the office for their hard work in bringing all of this together. The Vision Special Interest Group, Sean Chen, Martin O'Brien and Fiona Kearns, the Dr. Brenda McDonald, as I mentioned, for the pregnancy leaflet, and our Stroke and Neurology Special Interest Group, for example, Dr. Norman Delante, among others. The RSA were very helpful in the production of the guidelines, and both Declan, but John Paul Guaheen and the RSA producing a very elegant and much more readable final version. And I'd like to thank the college and Professor Horgan for their continued hosting and support. And we will be communicating with the new information leaflets and dates for our certificate in traffic medicine, our certificate in road safety and health, and our clinical update on driving and alcohol and substance abuse very shortly to all involved. So where I would say lastly is just to remind people, if I can share my screen once more, I'm screen sharing 1 second, is our website, rcpi.ie/traffic medicine, contains all of these elements. And one of the new things we've put up is alternative transportation for those who can no longer drive. And this is something that we will be promoting in future, because all of us will at some stage have to take a temporary break or a permanent break from driving. And I think it's important we know what resources are available and push for them. So thanks very much for your attention. We've come in a little under time, and this webinar will be mounted on the website shortly. Thank you very much to all.